as well as recommendations for additional reading. So let's get started. Why learn about supplements? Well, some patients you're going to encounter ideologically just prefer non-prescription treatments. They're often influenced by others to consider these treatments, friends, families, news media, therapists. So it's essential during your treatment planning for you to be thoroughly knowledgeable about the supplements so you can help ensure the patient's safety. And also, I think what you will find is your knowledge of supplements and your willingness and openness to discuss them will enhance your therapeutic alliance with your patients and clients, and also encourage them to disclose when they're thinking about taking supplements and when they're already taking them and you may not know about them. So that's why it's important for us to be discussing. Let's talk about the concept. Alternative is saying by definition that we aren't sure about the safety, we're not sure about the tolerability, or we're not sure about the efficacy. So when treatments meet these criteria, they lose the title of alternative and become mainstream. So if you're restricting your treatment options for patients to only alternative treatments, or if patients are doing that to themselves, they're getting denied the opportunity for the safest, most tolerable, and most efficacious treatments. So hopefully today you'll learn more about what we know about these so-called alternative treatments and how mainstream they can be for you. An important issue in working with patients who want alternative treatments is that they tend to value the word natural. They tend to equate the word natural with safe,
this will be my third year in a row doing
it. And as we know, all natural things are not safe, healthy, and effective. Think of arsenic, for example. So what we want to do in the conversation with our patients is eliminate the word natural and replace it with the word proven, meaning that it has been proven to be safe, it has been proven to be well tolerated, and it has been proven to be effective. And I think that this will help you in your treatment planning and treatment monitoring. So are there any possible risks with supplements? Well, yes, there are. First of all, the cost. Sometimes supplements cost hundreds of dollars per month, and they're often not covered by a patient's insurance if they have the insurance for that. It can be much more expensive than prescription medication, particularly a copay or a generic version of a medication that would be acceptable. There's also little government oversight. Keep in mind that the quality of supplements is not regulated. They're not regulated for safety, for truth in advertising, or quality control until something really egregious happens. The best example is in 2004 when the United States government decided to ban ephedra. Finally, even though many of us have been calling for it for a long time. So don't assume that unless the whole public is aware of an issue that the government, any of the governments on earth, have done anything about them. Counterfeit preparations are a significant problem. Some purchases may contain the substance in very small amounts or often not at all. And worse, sometimes undisclosed ingredients such as allergens can bring other health risks. There have been attempts to certify manufacturing practices, but unfortunately these have also been counterfeited as well, so buyer beware. And then additionally, there are risks of drug-drug interactions with supplements, just like there are prescription medications. For example, serotonin syndrome, which as she was saying, our next talk is going to be on adverse events, and serotonin syndrome is something we're going to be discussing. But just like medicines that go through the cytochrome P450 system for metabolism, so do many of our supplements. And this can cause interactions that are going to cause problems for your patients. So what are the supplements we're going to discuss today? We're going to talk about Johns Wort, Sammy, Ltryptophan, melatonin, Lmethylfolate, vitamins B12 and D, omega-3 fatty acids, Valerian, Kava, Ginkgo Biloba, and Ginseng. So let's get into it. Let's talk about St. Johns Wort. St. Johns Wort was extremely popular in Europe, particularly Germany, and eventually the United States in the 1980s. There were over 70 published studies that purported that it was efficacious in the treatment for major depression. I read every single one of those, and let me tell you that they were all poorly done, not valid studies. And because no prescription was necessary for St. Johns Wort, this became a something popular with patients in the U.S. who didn't want the stigma of going to a psychiatrist, or the expense or bother of going to a psychiatrist, or even a family practitioner. And so it became very popular. It has been definitively established through randomized clinical trials and meta-analyses that St. Johns Wort does not treat major depression any better than placebo, no doubt. And you might say, well, it's harmless. Why don't people just take it anyway? Well, because there are significant side effects, gastrointestinal, confusion, dizziness, sedation, tiredness. And then again, we're back to drug-drug interaction risk. Serotonin syndrome. It can stimulate serotonin, not enough to treat depression, but enough to interact with other medicines that are affecting serotonin, and that can be medically dangerous. And again, it's interacting through the metabolism with other drugs. Here's some examples. Its induction of 3A4 will lower the serum levels of oral contraceptives, which may allow pregnancy. It will interfere with HIV treatments, cyclosporin, and even anticonvulsants, such as carbamazepine, phenobarbital, and Dilantin. Through its induction of 1A2, it will again lower oral contraceptives and theophylline, which are asthmatic patients may be taking. It will lower the levels of warfarin through 2C9. And if a patient needs an anticoagulant treatment, you're limiting its benefits. And then through the induction of transport protein, P-glycoprotein, it lowers levels of digoxin, which your patients will need for their cardiac health. Similarly, stopping St. Johns Wort may raise the levels of these medications. So be warned that even occasional use on their own to supplement these traditional treatments can be dangerous. Your patients need to be made aware of this. All right, let's move into Sammy. Now, Sammy, the theory behind it is well-grounded in science. There is a rare inherited error of metabolism leading to lower levels of folate and vitamin B12, which are cofactors in the synthesis of Sammy. And this leads to interference with myelination and the biosynthesis of the monoamine neurotransmitters that we're commonly affecting with our psychiatric treatments. And this can result in dementia and depression. It's an extremely rare inherited error of metabolism, so low that no one recommends even bothering to check for it. And then randomized clinical trials to test whether or not giving patients Sammy can actually reverse symptoms have not been done well enough for us to be able to answer whether or not it's helpful. And then, of course, there are side effects, such as hypomania can be induced, gastrointestinal side effects. It can also lead to agitation and anxiety, whether or not it's helping. As with St. Johns Wort, public acceptance and use of Sammy has outpaced scientific review and confirmation. And you heard me say earlier that there are studies of going to the pharmacy or store and buying preparations that are available over the counter and analyzing them back at the lab to see what's there. And one of the most famous studies was actually on Sammy, where it found that almost everything that was available did not have Sammy available at the levels it said it did, and many preparations didn't contain Sammy at all. All right, let's look at Ltryptophan briefly. Obviously, this is an amino acid. This is used as a soporific. It's basically a glass of warm milk or a big turkey dinner. It was popular in the 80s because in the 80s we didn't have a lot of safe sleeping pills. So a lot of people were throwing this in just to help when you kind of didn't want to give a sleeping pill, but you wanted to do something to help. The problem is in 1989, it became associated with the sudden appearance of an eosinophilia myalgia syndrome, or EMS, in the United States. And therefore, it began to be banned around the world in 1990. It subsequently was learned that the Ltryptophan itself was not causing the EMS. It was an impurity from one manufacturer. But by that time, it had such bad press and people were so worried about it that it kind of just fell out of everybody's armamentarium and people quit using it. By 2005, all of the bans around the world had been reversed. So it is available, but people really aren't excited about using it that much. And we have much better and safer treatments for sleep now. Now, it is a serotonin precursor. And so some people have often wondered if it can be used to treat mood. However, data backing that up is absent. We don't have anything to prove that or disprove it. Interestingly enough, it is also a precursor through serotonin to another popular over-the-counter agent used for sleep, melatonin. Let's talk a bit about melatonin. Melatonin is an endogenous hormone released by the pineal gland. And controlled studies show that it can help with initial or delayed phase insomnia. However, even though it's touted often for jet lag and shift work sleep disorder, the data backing this up is weaker. So if you're going to be recommending it, you're really going to recommend it for people who have trouble getting to sleep at the beginning of the night. Now, short-term dosing in controlled clinical trials usually ranges anywhere from 0.3 to 5 milligrams at bedtime. The difficulties with melatonin are that there's a great variation existing in the quality of the melatonin preparations available, especially in the United States, where it's unregulated, and it's not at all standardized in the controlled clinical trial. So it's hard to draw conclusions. And although it's well tolerated short term, because its sedative effects are desirable, we're wanting that side effect to be our primary effect, the long-term safety of melatonin has not been established. And as an endogenous hormone, it has many delicately balanced effects, and its secretion, normally linked to darkness in the day-night schedule, is inhibited by exogenous dosing. So you may be screwing things up that are very important and be totally unaware of it. Patients and non-patients are often determining their own doses and schedules, so the risk of various doses and long-term use needs better assessment. So until we have that, it is clearly not recommended for children, adolescents, during pregnancy, or during breastfeeding. Now let's move into Lmethylfolate. Lmethylfolate became popular with many practitioners in the 21st century when manufacturers received FDA approval and aggressively marketed the supplement as Deplin for treatment-resistant major depression. This was based on observations that these patients sometimes have low levels of folate in their serum or cerebrospinal fluid, and sometimes success was achieved with oral replacement of either folinic acid or Lmethylfolate. So let's go through the pathways that are important here. We start with dietary folic acid, and then the enzyme MTHFR converts it to Lmethylfolate. This increases the cofactor BH4, which activates the enzymes tryptophan hydroxylase and tyrosine hydroxylase, which themselves are the rate-limiting steps for the synthesis of serotonin, norepinephrine, and dopamine. So you can see that these steps, this enzyme with MTHFR is going to be very important. There are many different polymorphisms of this enzyme, particularly the one labeled 6,7C. And this has been theorized to block the conversion of the dietary folic acid into Lmethylfolate, leading to treatment-resistant depression. So, when we know that there's low levels of serum folate, oral Lmethylfolate can be used. It crosses the blood-brain barrier, so it gets into the brain, And then we know from well-done trials that a 15 milligram dose may be effective over 30 days and sustained for at least 12 months. That's as long as it was studied. And interestingly enough, a lower dose, 7.5 milligrams, is ineffective, which makes it more encouraging to know that we probably are seeing a real effect from the 15 milligram dose. What's crucial to remember, however, is that it can be effective at treating so-called treatment-resistant depression when it's used as a supplement to traditional antidepressants, never useful when it's used as the only treatment or as monotherapy. It has to be a supplement. Now, what about giving oral Lmethylfolate to treatment-resistant depression patients with normal serum levels of folate? Well, it's only yielded modest response. It's not always effective. Not all patients have low serum levels at the time of treatment. And there's another similar folate problem called cerebral folate deficiency we're going to talk about in a minute. And measuring the serum level is not going to detect that. And you're not treating cerebral folate deficiency the same way. So it won't be effective in that case. And I just put a little mention in here about the BH4 step. We do know that if that's low, we have ways of treating that with analogs as well. So cerebral folate deficiency, as I said, correction can be effective in 1/3 of cases. However, it cannot be diagnosed with serum or erythrocyte measurements. And if you have to measure the folate in the cerebrospinal fluid. And if you've already given oral Lmethylfolate, you will distort the levels in the cerebrospinal fluid, and then you won't be able to make the diagnosis. So if you're suspecting cerebral folate deficiency, you must test the cerebrospinal fluid prior to oral supplementation. The treatment for cerebral folate deficiency is paroxetine with folinic acid. Now, there are many, many commercially available tests for defects in the MTHFR enzyme that are being touted as telling providers whether or not they should be giving folate treatments. This is not the best way to proceed. These tests on the polymorphisms are not reliable for treatment guidance. They are easily misinterpreted. And some of the reasons for that are that 60 to 70% of patients have at least one abnormal form of the gene. And there can be multiple abnormal forms. So using these tests of the abnormal enzyme is not indicated for any medical disorder, including mental health disorders. So what you want to test for is the serum or the cerebrospinal fluid folate levels instead. In other words, let's not go with a just try it anyway approach. Make sure that you've documented a low folate level, because new data are demonstrating adverse events such as cognitive impairment and possible tumor growth from high serum folate levels. So we want to make sure that we're avoiding that. Our take-home lessons from this example are routine or impulsive supplement use may obscure the actual pathway to treatment success, and genetic testing, though popular, is expensive and may be confusing and may be misleading. Now let's move into vitamin B12. We know that this is an essential vitamin for the methylation of our monoamine transmitters that we're affecting. And we know that so-called normal levels of serum B12 are inadequate for over half of the population, particularly older patients. We know that deficiency of B12 can contribute to cognitive impairment and in some cases, depressed mood. In controlled clinical trials, however, just replacing B12 doesn't seem to treat cases of cognitive impairment or depressed mood, although if you're replacing it long-term, it does seem to reduce the recurrence of major depressive disorder. We want to talk about the link in diagnosing vitamin B12 deficiency based on serum folate levels. And the reason this is so important is it's easy to misdiagnose vitamin B12 deficiency. I have this chart in the book. It's something you want to cut out and put it in your desk. because you're really going to need to follow it again and again and again. And basically, as you can see, we'll be measuring not only B12, but folate, methylmalonic acid, homocysteine at times. The bottom line is, if your vitamin B12 level is low and your folate level is low, you can't tell whether it's really a low B12. You've got to replace the folate and then repeat the test. And then once you've got normal folate, if you still have a low vitamin B12 level, you can diagnose B12 deficiency. All right, what about if you've got a low normal level? This happens a lot in clinical practice. It's not completely abnormal, but you're still suspicious. Again, if you've got a low folate level, all bets are off. You need to replace folate and repeat the test, even if your homocysteine is high. If you've got normal levels of folate, though, and low normals of B12, you can use methylmalonic acid or homocysteine to be helpful. So low normal level of B12, high level of methylmalonic acid, yes, you can diagnose B12 deficiency. Same thing with a high homocysteine level. If you've got a low normal level of B12 and folate is normal and methylmalonic acid is normal and homocysteine is normal, however, there's no B12 deficiency. So look at all of these possibilities, and the only 3 times we can diagnose B12 deficiency on this chart is when you've got normal folate levels. That's something really crucial to remember. All right, now let's jump into vitamin D. There have been mental health concerns about vitamin D deficiency, including mood, psychosis, eating disorders, and cognitive function in psychosis and aging. Many clinicians have been concerned about vitamin D levels in general, though, for several decades. They begin to worry about cardiovascular disease, stroke, type 2 diabetes mellitus, and colorectal cancer, in addition to the already knowledge things we knew about, like rickets, osteopenia, and osteoporosis. And unfortunately, like some of our other supplements, even if vitamin D is associated with these mental health issues, replacement of low levels so far has not been therapeutic in randomized clinical trials. So let's talk about vitamin D deficiency in general, though, because it is found to be global in all age groups, despite most industrialized countries supplementing endogenous production with fortified foods, usually containing the plant-based ergocalciferol, which we know is D2. Dietary sources otherwise are very weak in vitamin D, except for fatty fish, where we have D3 or cholecalciferol. All right, so this is probably going to be our most complicated slide, but we'll get through it just fine. So we've got the D2, which can be thought of as the plant vitamin D. It has less affinity for the body to metabolize it, and it exits our bodies quickly. So basically, if you're going to be depending on D2 replacement, you're going to need to be giving it daily. It really won't build up. Now let's talk about D3, or the cholecalciferol, or the so-called animal vitamin D. We can obtain that from fatty fish in our diets, but we also produce it in our skin. Most patients are aware that we're creating vitamin D in our skin, although they probably over-rely on that. This is how it happens. 7-dehydroxycholesterol is altered by ultraviolet B radiation and heat. This is limited by how much UVB people are exposed to, either by the seasons, wearing clothing, sunscreen, which of course they should be wearing, and how much melanin there is in the skin. Now, it's metabolized in the liver to 25-hydroxyvitamin D, which is the major circulating form of vitamin D in the bloodstream. And then the kidney further metabolizes 25-hydroxy to the 1,25-hydroxy, which is actually the active form. This process is regulated by the parathyroid hormone and levels of calcium and phosphorus. See, we got through it just fine. Now, if we're going to assess a patient for vitamin D, we don't really want to measure the active form, the 125. And you can do that, but what you really want to order is the 25-hydroxy, the major circulating form. That's what most of our levels have been standardized on. There isn't complete agreement about what's normal and abnormal. The Institute of Medicine in the US, for example, lists that levels of 20 nanograms per milliliter or 50 nanomoles per liter are sufficient. Notice that these are very close numbers, 20 and 50. So you're going to need to pay really close attention to what the units are when you're assessing this. Are you looking at nanograms per milliliter, or are you looking at nanomoles per liter? For 97% of the population, the Institute of Medicine says these levels or higher are sufficient. The Endocrine Society, however, has added another level calling insufficiency. They have below the original amount is deficient, but then they have a medium range of 20 to 29 nanograms per milliliter that is insufficient. And they would recommend treatment during the insufficient. So if we're going to replace vitamin D, how are we going to do it? Well, as we've already said, the D3 form is superior. It hangs around longer, and it can build up, and it is open to the metabolism. So often, 50,000 international units can be given orally, twice weekly, weekly, monthly. Many clinicians have their own pet way of doing this. I particularly like to give it daily because, frankly, it's a lot easier for a patient to remember a daily medication or supplement than it is twice weekly, weekly, or monthly. And you can usually target 2,000 to 4,000 international units daily. But if you're going to do this, you must monitor the patient's vitamin D level. We're going to get into the toxicity of vitamin D in just a minute, and we must avoid that. Now, when this became popular in the news media and everybody was aware that vitamin D might need to be supplemented, a lot of people just started taking it on their own without monitoring. So the powers that be had some conferences to decide, all right, if people are taking this unregulated, what's a safe level to tell them that they could consider? And what they came up with are very low doses. 60 international units daily for most adults, 800 if you're older than 70. And as you can see, that's significantly lower than what most people are going to need. So the bottom line is, if you know that your patients are taking vitamin D, you must encourage them to be monitoring the levels, and you certainly don't want to be prescribing it unless you know that they are monitoring levels. And why? Because of vitamin D toxicity. We remember that vitamins A, D, E, and K are fat soluble. They build up in the body, unlike B and C, which are water soluble. And that we know that high serum levels, again, pay attention to the units, greater than 50 or greater than 125, can lead to kidney stones, especially when patients are also taking calcium, and also to hypercalcemia and hypercalciuria. And the clinical presentation of these two conditions involves polyuria, cardiac ectopy, gastrointestinal distress, vascular calcification, and look at this, depression, lethargy, confusion, and hallucinations, which might be symptoms of our primary disorders that we're trying to help our patients with. In addition to vitamin D toxicity, there are some patients who are just simply sensitive to vitamin D, even at lower levels. These are patients with primary hyperparathyroidism. Remember, the parathyroid hormone is a rate-limiting step influencer. And patients with granulomatous disease and even some cancers. So we want to avoid vitamin D toxicity at all costs. Now let's move into omega-3 long-chain polyunsaturated fatty acids. Are these useful for major and perinatal depression? I like to think of omega-3s as representing a compelling theory seeking confirmation. It's just an elegant theory of why it should work, but of course, we know that medicine has been littered with beautiful theories that didn't turn out to be accurate. Why is it a beautiful theory? Well, what's in the structure of cell membranes? Fatty acids. The fatty acid alpha-linolenic acid is converted to EPA and then further to DHA. And the conversion is limited in humans, and many polymorphisms of the enzymes that accomplish this are existing. We know that fatty fish in our diet may supplement the level months, particularly in women with multiple pregnancies. We know that high ratios of omega-6 to omega-3 have been shown to reversibly alter serotonergic and dopaminergic transmission, including during lactation, at least in animal models. And we know that low serum levels of omega-3 relative to omega-6 is associated with major and perinatal depression. So, given all that information, can supplementation with omega-3 as EPA or DHA prevent the development of mood disorders, especially in the peripartum period, or assist in their recovery? Well, we have many open label studies. An open label study is when everybody knows what everybody's taking. There's no double blind, so you are open to confirmation error, but that is one step in the process. We have many open label studies that are very encouraging that it might be helpful. However, when we move to randomized clinical trials where we have a double blind, the results are conflicting. This may be because of how difficult these studies are to do. The early studies utilize flaxseed oil, but its conversion to EPA is highly variable in humans. So fish oil is now the standard, and this complicates double blinds because patients often reported burping a fishy smell, which is hardly practical, and made the double blind much more difficult to manage. So that probably muddied the water on whether or not it's actually going to be helpful. A recent meta-analysis shows that indiscriminate use of omega-3 to prevent or treat depressive illness is just not justified. You just don't want to be throwing it at everybody. EPA form, however, as monotherapy or as a supplement to antidepressants, significantly superior to ever using DHA. I've noticed in the last few weeks, this is coming out almost daily, new studies on that the DHA part takes away from any benefit you'd be seeing from the EPA part. And again, we want to be thinking of this supplementation really in patients meeting the criteria for major depression. So any omega-3 used for major depression should have a much higher proportion of EPA than DHA. Unfortunately, though, supplementation and monotherapy with omega-3, even the EPA, in peripartum depression, which remember is cases of DHA depletion, has not been successful in open studies or randomized clinical trials. Are there other uses in mental health for these fatty acids? Well, there is a possible benefit for mild cognitive impairment, but not for Alzheimer's. There has been no symptom reduction in ADHD in children or adolescents, and we have insufficient data to know about its effectiveness and use for other psychiatric disorders. It may help patients with existing atherosclerotic cardiovascular disease, but there's a weak indication about whether or not it's actually helpful for stroke, heart disease, diabetes mellitus, or pre-diabetes. Now let's talk about toxicity. As you know, we're talking about fish, and fish contain mercury in our world, unfortunately. And it's difficult to come to a general recommendation around the world because of the variations in the fish species, variations in the mercury levels, local dietary habits, and local dietary guidance. Plus, again, there's no standard dose that's recommended or used in any of these controlled studies. But the bottom line is that most experts think that for the average person, the risk of the mercury toxicity is low enough to where it's not going to stand in your way of considering this as a treatment for major depression. However, you do not want to recommend it for women who are pregnant or nursing. And remember, if you're thinking that the pregnant and nursing women need it for peripartum depression, we've just shown that it really doesn't work in open label or controlled studies. And I just want to mention that recently in the literature, there's been some mention of these fatty acids increasing the risk of prostate cancer and also treating prostate cancer. All we can say at this time is there's insufficient data. We can't draw any conclusions either way on that. So our bottom line with omega-3 fatty acids is encourage your patients to identify a clear clinical indication before continuing supplemental fatty acids begun without a prescription or with clinical direction, no matter what health problem they want to target. And now we're going to move into other herbal preparations you might encounter. Valerian. This has been used for centuries as a soporific or sleeping pill. It, however, in contemporary meta-analyses for sleep has been found to not actually be effective objectively. However, some patients have a subjective sleep experience that's better. They think it made them sleep better when actually it didn't. And so it can be recommended for improvement of the subjective experience if necessary. Some people claim that it's helpful for anxiety. Again, our studies for that are conflicting. We can't say yes or no. And there doesn't appear to be any apparent toxicity with valerian. So again, it might be helpful subjectively, objectively, not really, but it's apparently safe. Now let's move to Kava Kava. This is a drink from Pacific Island communities used in cultural ceremonies. It's also available in extract, capsule, and pill form. And it can be useful for short-term use of anxiety. However, look at this in red we've got here. Severe hepatic toxicity. It is poisonous to the liver. So therefore, you're not going to want to use it any longer than 8 weeks. That makes it inferior to our traditional medications for treatment of anxiety. So it's something you'd really only want to recommend very, very thoughtfully. And of course, your patients are going to need to know about the hepatic toxicity so they don't get themselves in trouble. Now I want to talk about Ginkgo Biloba, talking about getting into trouble. The wide public acceptance of Ginkgo Biloba for the prevention of cognitive impairment is not at all justified. It does not work. It does not prevent progression from normal cognition to dementia or normal cognitive function to mild cognitive impairment. So get the word out. This is something that be avoided. This is not a benign supplement. It has many health risks. For example, again, we're going through the cytochrome P450 system with 2C19. It's going to lower anticonvulsant levels, which can be very important for your patients. It has hemorrhagic consequences. It increases chances of bleeding, particularly when it's combined with anticoagulants and platelet aggregation inhibitors, like even simple aspirin. And it's now listed as a possible carcinogen. So please educate your patients that Ginkgo Biloba should not be appearing in any treatment plan. Let's talk about ginseng. Ginseng is very popular worldwide. There are greater than 10 different varieties or imitators. In journals, when you're reading about ginseng, they're often going to be talking about the oriental ginseng. However, widely available at the stores, there's the American wild or cultivated ginseng. If you're reading about white ginseng, this is usually the natural unprocessed form. And then you might read about red ginseng, which is preserved with heat and steam and is of a higher potency. Well, why do people take ginseng? They often take it to fight off fatigue. And for this reason, high doses or long-term use may also lead to insomnia or nervousness. And it has been reported to provoke mania in some cases. Some people who really don't have mood problems have taken it to boost mood. And we know that in controlled studies, it actually does not do that. So there are other popular supplements that we don't have enough data on for mental health problems. We know zinc can be helpful with some viral syndromes, but we don't know anything about it in mental health. Vitamin C has never shown sufficient data to recommend its use. Same with inositol, mixed amino acids, creatine, and South American berries. So what are our key points that we want you to take home about supplements today? First of all, remain aware of every substance that patients are taking. You have to ask them at every contact. We're talking about things that they have in their shelf that they might take occasionally, things they used to take that they might start taking again. You need every conversation you have with the patient needs to review everything they're taking, and they need to know that you mean the non-prescription things as well. We need to be evaluating the safety and efficacy for supplements in the exact same way as we would for prescription medication. Remember that your familiarity is more likely to influence patients to look at the science behind supplements, to bring them up, to discuss them with you. And as we like to educate our patients and clients as much as possible about our traditional treatments, we need to be doing this as much for supplements as for those. So therefore, the provider knowledge of these supplements is very, very necessary. I want to thank you for attending today, and I want to open it up for questions. You can get more information from my website, or if you have a specific question, you can email me. I'd be happy to try to answer. So I'll open it up now for questions.
So everyone can just type their questions on the bottom right. We've not unmuting anybody. So I request you all to type the questions, and then we can, Dr. Putman can respond. So Scott is asking, is the prescription vitamin D3?
I'm sorry?
Is there a prescription vitamin D3?
No, it's not necessary by prescription.
I see. Jan was David is saying he apologizes if he missed it, but did you discuss melatonin re-efficacy and doses?
I did. What we said is that it's helpful for getting to sleep at the beginning of the night. What we said is that there's no agreement on what doses are, and there's great variety in the quality of the preparations available. So even if you think you're prescribing a certain dose, the actual amount that gets into the body may be very different. The ranges is somewhere from 0.3 to 5 milligrams. We just ask you not to give it to children or adolescents or pregnant or nursing women. Remember that it affects your body's endogenous release of melatonin, and that can, it's a finely tuned system, and we might be blindly influencing it without knowing. But it does appear to be somewhat helpful for just getting people a little drowsy in the evening if you're careful in using it.
That's fantastic. Actually, Aizan has a question. He's saying that melatonin is supposed to be given at sunset. Is that the case?
Well, that's quite reasonable. Remember, melatonin is secreted by the body naturally as dark hours come on, as twilight comes on. That's when it's going to be secreted. That's one of the reasons you want your patients to be avoiding blue light, because that's when the melatonin is supposed to be secreted, and then that prepares you for sleep. So yes, giving it at sunset is quite reasonable if that's what you would like to do.
I see. And then Ryan has a comment on melatonin as an intervention for patients with hypoactive delirium.
I'm not at all aware of any data on that. I'm sorry.
I see. And Barbara has asked for an email address for you in the chat, and a few of folks have asked for the slides. We shall be sending an email out and sending it out to everybody.
I see somebody ask about Lmethylfolate. Yeah, I had a long talk about that. I'll be happy to go over some of it again if you would like. If there's no other questions, that's going to take a while. If there's any other questions, we could get to them first while I prepare to go over that again.
Yes, there's Jan also who would prefer that you go over that real quick.
The Lmethylfolate?
Yes.
Okay, I think we have time to do that. As you know, it's been popular since they came out with Deplin and have been marketing that. Based on observations that patients sometimes have low levels of folate in their serum or cerebral spinal fluid, and that there has been some success dosing it at certain levels with either folinic acid or Lmethylfolate. The reason is that there's dietary folic acid is converted to Lmethylfolate with the enzyme MTHFR. And there are polymorphisms of this enzyme that affect people. in 60 to 70% of the population. So one of the points I made is please don't order a genetic test to find out if your patient has an abnormal version of MTHFR to guide treatment. That is not helpful at all. What you need to do is measure their serum folate levels. If you think they have cerebral folate deficiency, measure it in the cerebral spinal fluid. But definitely don't count on an abnormal enzyme test. That's not going to be helping you. We do know that oral Lmethylfolate in patients who have low serum levels of folate, we know it crosses the blood-brain barrier, gets into the brain, and that a 15 milligram dose is effective over 30 days, and the benefit has been found to be sustained for at least 12 months. And we know that lower doses, such as 7.5 milligrams, are actually ineffective. And again, the key point here is that you cannot use it as monotherapy. You can't just give Lmethylfolate. You have to give it in addition to the standard antidepressant that you would be giving. So hopefully, in a nutshell, that's helpful to review that for you.
I guess we have a couple more questions. Barbara said, how does your knowledge of the body affect your own diet?
Mine? I try to be sensible. I took extra courses in nutrition in medical school. I've always tried to be sensible and to follow the scientific literature. I think that's as much as I care as much about the scientific literature telling me what to do as I do my medical knowledge. So again, be guided by the science. We try to practice evidence-based medicine. There's never enough evidence. So for heaven's sakes, let's use the evidence that we do have.
Okay, fantastic. And then why can low folate levels cause falsely low vitamin B12 levels? Ryan had that question.
You know, I honestly don't know the answer to that, but you've encouraged me to go look it up. I used to know a long time ago it wasn't clinically relevant, so I didn't retain it. I'm sorry about that, but it's undeniable. You've got to look at the folate levels if you're going to be diagnosing B12.
Okay, David, thanks you for a good presentation and good review. And Jan is requiring a copy of your presentation. Eisen had one more question. How would MTFH testing be applied to it as well?
Do not do it. I mean, that's the bottom line. Please don't do it. Remember, 60 to 70% of the general population is going to have an abnormality, and not all of those people are going to have low serum folate levels. So ignore the test for the abnormal enzyme. In every medical condition there is, this is the recommendation. And just measure if you're thinking it's, just measure the serum levels of folate. And if you're thinking cerebral folate deficiency, and of course there's criteria for looking at that, you want to measure it in the cerebral spinal fluid, and you want to measure it in the cerebral spinal fluid before you give oral folate. But please don't order the genetic test. It will not help your patients at all. It will just confuse things, and it's an expense and it's not necessary.
I see. And then Barbara has also one more question, is that can you do a presentation on cannabis, if that's your area of knowledge?
Well, I know a lot about it. I can do that. I wouldn't say I'm the world expert on it, but in my book, I of course cover that and reviewed that. I'll be happy to consider that, yeah.
Okay, and Lena has a question, how supplements can be in conflict with prescribed antidepressants and anti-anxiety meds?
Well, as we were saying, one of the greatest ways they can do that is drug-drug interactions, affecting the metabolism of other medications, including our psychiatric medications. Again, serotonin syndrome is going to be one of the very best examples of that. You can have serotonin syndrome from just high levels of serotonin effect from a single medication, but it's much more likely if you're having multiple effects from multiple medications, raising your serotonin levels. It's not an idiopathic problem. It happens to everybody who's got too much serotonin stimulation. So that's a real good example of needing to know exactly what everybody's on. When you see an adverse event present itself, you've got to know what everybody's taking. As we were saying, our next webinar will be on adverse events, including that. But that would be one of the most important reasons, is that you're affecting the serum levels of other medications.
Okay, fantastic. I think we can take one or two more questions if anybody has any questions. Okay, so I want to thank everybody as well as Dr. Putman for such a wonderful presentation. It was definitely informative, and thank you everybody for your time.
Thank you very much.